Okay, let's unpack this. Imagine a child. It seems perfectly healthy one day, and then suddenly they start developing weakness in their limbs. This isn't, just a minor thing. For doctors, for clinicians, it's a pediatric emergency. We're talking about acute flaccid paralysis, or AFP. The World Health Organization defines it pretty simply: the acute onset of muscle weakness, showing up in less than 5 days. Today, we're taking a deep dive into AFP. It's a condition that, well, it can be incredibly challenging to diagnose, let alone treat. Our mission, to sort of demystify its surprisingly diverse causes. We'll walk you through the critical medical detective process of diagnosis, and we'll shine a spotlight on the unique and sometimes really counterintuitive treatment paths, especially for one specific type that's a growing concern: acute flaccid myelitis, or AFM. We've pulled insights from comprehensive reviews, things like articles from Springer Nature and the Journal of Pediatric Critical Care, just to give you the clearest picture we can. Yeah, and what's truly fascinating here is just how broad the spectrum of AFP can be. It makes it a real diagnostic puzzle for clinicians. You have to consider everything from sneaky viral infections to incredibly rare genetic disorders, even environmental toxins. And understanding the subtle distinctions between these causes, well, it's not just academic, right? It's absolutely life-changing for these children. We're going to show you how different parts of the nervous system can be affected and why pinpointing that exact location, that's the first most crucial step in a patient's journey towards recovery.
So, okay, the medical detective work. What exactly are we looking for when a child presents with AFP? Beyond that rapid onset of weakness, that initial approach is all about gathering the right clues, right? Precisely. Yeah, the detailed case history is the first big piece of the puzzle. This includes everything from the exact onset, like was it sudden or did it creep up over a few days,
Yeah.
any associated fever, recent immunizations, even family history of similar conditions. But, what's really astonishing sometimes about diagnosing AFP is how a seemingly minor detail, maybe a recent camping trip, or a specific type of cough they had months ago, or exposure to something unusual. That can be the single crucial clue that differentiates, say, a reversible condition from something really life-altering.
So it's not just about what they can't move, but also how they're breathing. That sounds like a really critical point for a condition like this.
Exactly. The neurological examination has to be meticulous. You're assessing not just the distribution of weakness. Is it the eyes, speech, limbs? Is it proximal, like shoulders and hips, or distal, hands and feet? But you also look for other key things. Cranial nerve involvement that controls things like facial movement or swallowing, any sensory changes, any signs of autonomic dysfunction like issues with blood pressure or heart rate. And you absolutely hit on the critical point. Vital signs and respiratory function are paramount. A simple bedside test, maybe asking an older child to count out loud on the single breath, that can immediately signal if their breathing is critically compromised. Wow, yeah. Highlighting the urgent need for potentially ventilator support. Yeah. It's all about that rapid assessment for respiratory failure.
That makes perfect sense. So when you're doing that initial assessment, the main goal is really to pinpoint where in the nervous system the problem is starting. Brain, spinal cord, somewhere else.
Absolutely. Think of it like this. Is the problem in the control center? That's the upper motor neurons in the brain and spinal cord. Or is it somewhere along the wiring that connects that center to the muscles? That could be the lower motor neurons in the spinal cord itself, the peripheral nerves carrying signals out, the neuromuscular junction where nerve meets muscle, or even the muscles themselves. Each location points you towards a different group of potential suspects, different possible causes.
Okay, here's where it gets really interesting, I think. One specific cause of AFP has really come to the forefront in recent years. It's almost like this recurring character in our medical detective story: acute flaccid myelitis, or AFM.
Indeed. AFM. It's characterized by injury specifically to the anterior horn cells of the spinal cord. You can think of these as the specific motor control centers, sort of the engine room that tells your muscles exactly what to do. And it's been increasingly linked to enterovirus infections, particularly enterovirus D68, EVD68, and enterovirus A71. We saw these concerning clusters of cases emerge, remember, back in late summer, early fall of 2014. And subsequent outbreaks led the CDC, the Centers for Disease Control, to establish clearer case definitions so we could track it more accurately. It predominantly affects children, from infancy right into young adulthood, but the median age seems to be typically between 5 and 9 years old.
And what makes AFM particularly challenging, as I understand it, is how much it can look like another condition: acute transverse myelitis, or ATM, especially at first glance when a child first comes in. But their underlying mechanisms are quite different, and that really matters for treatment.
That raises the key question, right? How do we tell them apart? The crucial distinction in AFM is that the spinal cord injury seems to be largely mediated by direct viral infection of those motor neurons. It acts a lot like poliomyelitis used to.
Yeah.
It's generally not considered a primary inflammatory process like we see in ATM. Clinically, AFM often presents with an asymmetric onset of flaccid limb weakness,
Yeah.
maybe starting at just one arm, for instance.
Patients might complain of pain or maybe a tingling sensation in the affected limb, but here's the interesting bit. Often without an apparent sensory deficit that you might expect with a typical nerve issue, bowel and bladder dysfunction. Also less common in AFM compared to ATM. Now, while that flaccid tone and absent reflexes are hallmarks of AFM, they can also occur acutely in ATM, which just, adds to the diagnostic challenge early on.
So the MRI sounds like it becomes the ultimate forensic tool here. What specific clues are radiologists looking for to tell AFM and ATM apart? Yes, exactly. MRI offers really crucial clues. In AFM, we're looking for very specific damage right in the spinal cord's engine room, the gray matter, especially that anterior horn. We might also see enhancement just to the ventral nerve roots. Those are the nerves carrying signals out from the spinal cord to the muscles. In contrast, ATM lesions typically involve the white matter, as the wiring carrying signals up and down the cord, or sometimes both gray and white matter. Also, brainstem lesions can be seen in AFM, but importantly, those supratentorial white matter lesions high up in the brain, above the cerebellum, common in things like MS, those are typically not present in AFM. That's a key negative finding.
And what about lab work? Is there like a definitive blood test, something that screams AFM?
Laboratory testing can be tricky. It's another layer of complexity for our medical detective. Enteroviruses are actually rarely detected in the cerebrospinal fluid, the CSF, which is the fluid around the brain and spinal cord. And AVD68, one of the main culprits, it doesn't really shed in the stool, so that makes it hard to find the evidence there. Respiratory samples, like a throat or nasal swab, offer the highest yield for detecting the virus.
Okay.
But even then, it might only be detectable within the first 5 to 7 days of the initial infection. And here's the real challenge. The neurological symptoms, the weakness, often presents days after that initial, often mild respiratory illness.
Ah, so the timing's off.
Exactly.
Yeah.
It makes it incredibly difficult to catch the virus in that narrow window when it's still detectable. The horse might have already bolted, so to speak.
So, okay, what does this all mean for treatment then? If AFM is primarily infection and ATM is primarily inflammation, do we treat them completely differently, or is it more complex?
Absolutely, we treat them differently. And this is where that diagnostic distinction becomes just critical, potentially life-saving even. For acute transverse myelitis, ATM, the thinking is it's an acute inflammatory attack. So it's typically managed first line with high-dose intravenous corticosteroids, often followed by an oral taper. Intravenous immunoglobulin IVIG and plasma exchange, PLEX, are also important. They're often used as adjunctive or second-line treatments, especially if the case is severe or isn't responding to steroids.
Okay, so that's ATM. What about AFM? If steroids are the go-to for ATM, is it the same approach?
Well, this is where it gets really counterintuitive and frankly quite concerning. For AFM, the picture is far more complex. There are currently no high-quality clinical trials to definitively guide acute treatment. In fact, the CDC has stated there's just insufficient evidence right now to endorse or discourage any specific treatments.
Wow.
But what we've learned from animal models has significant, even maybe surprising implications, particularly about corticosteroids. Studies in mouse models looking at EVA71 and EVD68 infections have actually shown that steroid treatment can worsen outcomes.
Worsen?
Yes, increasing mortality and actually increasing the amount of virus found in the spinal cord. Based on findings like these, the World Health Organization even concluded that steroids should likely be avoided in managing EVA71-associated neuroinvasive disease.
Wow. So a treatment that's standard first line for ATM could actually be harmful, detrimental for AFM. That's a huge, huge difference. So if steroids are probably out and maybe IVIG is a possibility but not proven, what does that leave clinicians feeling in terms of having truly effective acute treatments for AFM right now?
It creates an enormous challenge, absolutely. IVIG is often used sort of empirically for AFM, meaning it's tried because we don't have many better options and there's a theoretical rationale. While clinical experience hasn't shown clear, consistent evidence of improvement, those animal models do suggest it could be beneficial, but only if administered very early in the infection.
Very early. How early?
Likely within maybe the first 3 to 6 days.
Yeah.
Because of the neutralizing antibodies against the virus that might be present in IVIG preparations. The difficulty in clinical practice, though, is often initiating treatment within that incredibly narrow window, often before the neurological damage is too advanced. Plasma exchange, PLEX, is also used sometimes, but its appropriateness is really questioned for AFM because it's not thought to be primarily an antibody-mediated disease, and there's even a theoretical risk that PLEX could remove important native neutralizing antibodies the patient is making themselves, potentially hindering their own immune response.
That's complex. So it sounds like regardless of the specific cause, rehabilitation isn't just helpful, it's absolutely non-negotiable for these children.
Absolutely. Early and aggressive physical therapy, occupational therapy too, is a key component for the treatment of both ATM and AFM. It doesn't matter what the underlying cause is for this part, it's essential for maintaining flexibility, building stamina, minimizing pain and potential deformities, and really maximizing whatever muscle strength and functional outcome is possible for that child. And looking to the future, vaccination efforts against these enteroviruses like EVA71, they actually have vaccines commercially available in China for that one.
Oh, interesting.
Yeah, and EVD68 vaccines are under research. These offer significant hope for prevention down the line.
And for those more severe cases of AFM where the nerves are significantly damaged, are there surgical options being looked at?
Yes, nerve transfer surgeries have been explored as an intervention. There's been some success reported in selected cases. The basic idea is to reroute a healthy, functioning nerve to take over the job of a nerve supplying a paralyzed muscle, trying to reinnervate it. But there are limitations. It can be difficult to find suitable donor nerves, especially if the muscle dysfunction is widespread, which it often is in AFM. There's also some concern about potential viral injury to the Schwann cells. Those are critical for nerve repair, which might decrease the ability for a successful reinnervation. And the timing. The timing of such surgeries is also critical. If you wait too long, the receiving nerve and muscle might become less viable. It really is a race against time, like so many aspects of managing AFP.
Okay, so the medical detective has maybe narrowed it down to AFM or ATM. But what if the clues don't quite fit either of those? What other suspects are high on the list for acute flaccid paralysis?
Right, connecting back to the bigger picture. It's really important to briefly consider other significant causes of AFP that clinicians are always thinking about. For example, Guillain-Barré syndrome, GBS, is actually the most common cause of AFP in children in developed countries.
More common than AFM.
Generally, yes, overall. It's a post-infectious disorder, often popping up after a milder infection. Now, unlike the often asymmetric weakness in AFM, GBS is typically characterized by rapidly progressive symmetrical weakness. It often ascends, starting in the lower limbs and moving up, and usually absent reflexes. It can involve cranial nerves affecting the face or swallowing, and definitely can impact respiratory muscles. The key distinguishing clues often come from the cerebrospinal fluid, that classic finding of albuminocytological dissociation. High protein but normal cells in nerve conduction studies show specific patterns. Treatment, like some forms of AFP, often involves IVIG or plasma exchange.
And of course, we have to mention poliomyelitis, the sort of historical benchmark for flaccid paralysis that, thankfully, vaccines have almost made us forget.
Indeed. And while many regions, like India, for example, have been polio-free for years thanks to incredible vaccination efforts, it's still relevant to understand. It fundamentally shaped how we think about this type of paralysis. Poliovirus directly destroys motor neurons, leading to that characteristic asymmetric flaccid paralysis, often hitting children under 5. It typically had a biphasic illness, starts nonspecific, then rapid progression, notably no sensory changes. And mortality was primarily due to bulbar weakness affecting swallowing and breathing and respiratory failure. It's just a crucial reminder that other non-polio enteroviruses like the EVD68 and EVA71 we talked about, and even West Nile virus, can cause very polio-like symptoms today.
So, okay, it's not always a virus attacking the nerves directly in the spinal cord. What about issues right at the connection point, the neuromuscular junction, or even problems within the muscles themselves?
Excellent point. Absolutely. Disorders of the neuromuscular junction can definitely cause AFP. Things like botulism or myasthenia gravis. Botulism, that's an acute poisoning, often from a toxin made by Clostridium botulinum, especially in infants. Classically presents with constipation first, then poor muscle tone, maybe weakness of eye muscles, ophthalmal paresis, drooping eyelids, symptosis. Myasthenia gravis can present acutely as a myasthenic crisis, widespread weakness, but interestingly, often with normal reflexes. Pitosis and swallowing difficulties are common too. This crisis is often triggered by infections or certain drugs.
Okay.
Then you have primary muscle disorders, acute infectious myositis, for instance, often caused by influenza or enteroviruses. You see muscle pain, classically in the calves, and really high levels of creatine kinase, CK, in the blood that's a marker of muscle damage. And you can't forget familial periodic paralysis. That's a genetic condition causing acute weakness linked to low potassium levels, hypokalemia, often triggered by exercise or high-carb meal, maybe happening upon waking up.
And alongside looking for these specific diseases, you're always rapidly trying to rule out critical things that need immediate specific treatment, right?
Absolutely. That's priority number one for the medical detective. Rule out anything urgent and potentially correctable right now. That includes conditions like compressive myelopathy, maybe a tumor, an abscess, or hematoma pressing on the spinal cord. That needs immediate neurosurgical consultation and often imaging, or even that hypokalemia we just mentioned. That can cause profound paralysis but is rapidly reversible just by correcting the potassium level. This is exactly why urgent neuroimaging of the spine, usually an MRI, is warranted in pretty much any child presenting with features that suggest a spinal cord problem. You have to look quickly.
Wow. What an incredible journey into acute flaccid paralysis. From those really nuanced distinctions between AFM and ATM to the critical, sometimes life or death importance of treatment choices based on what's actually causing the problem. It's clear this is anything but a straightforward condition. That blend of careful clinical observation, advanced imaging like MRI, and trying to get the right lab work at the right time, it's truly a dance of diagnostic mastery, isn't it?
It really is. And if we connect this back to the bigger picture, the absolute key takeaway is that AFP is a true medical emergency with this incredibly diverse range of potential causes. Pinpointing the exact etiology, especially for these emerging conditions like AFM, is just paramount for guiding treatment. Because, as we've seen, interventions that might help one condition can actually harm another.
Yeah.
It just underscores the critical need for rapid diagnosis and a highly individualized approach to care for every child presenting with this.
And this raises, I think, an important question for you, our listener. Given these ongoing challenges in getting an early diagnosis and the lack of definitive proven treatments for some of these devastating conditions in children, like AFM, what further research or surveillance or maybe even global health initiatives do you think might be needed to truly prevent and treat acute flaccid paralysis more effectively in the future? You're definitely now better informed on a critical pediatric neurological emergency. Until next time, keep exploring.